ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the Files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Jen Braun.
Thanks, Stephanie. Hello, everyone, and welcome to our monthly webinar. My name is Jen Braun, and I direct the AHA Team Training Program. We're really excited to have you join us for our webinar, It's Time to Build Our Escape Fire. This webinar is presented by Ross Ermintrout, who you'll hear from momentarily. This is meant to be a sneak peek to what you can expect at our upcoming Advancing Care Conference, which I'll share more about here in a moment. But first, before we get into it, just a few rules of engagement to highlight. You can access audio for this webinar by either dialing in through your phone or by listening through your computer speakers. And if your internet is unstable, your best bet is dialing in through your phone, which the number and passcode can be found in the notes pod just above the chat. All hyperlinks are live, so keep that in mind. And like Stephanie said, you can download a copy of today's slides in the Files pod on your lower left. Finally, I'll moderate a Q&A session at the end with Ross. So if you have a question throughout the webinar, please chat them in. I'll save them through the end and order them in a logical way. We'll do a bit of a facilitated Q&A session. We're happy to offer free CEs for our webinars. In order to claim your CE credit, you must create a Duke OneLink account. This is a one-time only setup, so if you've done it in the past, you don't need to do it again. Instructions can be found in the Files pod if you need to do so, but following the webinar, please text SOSKER, the number you see there. We'll share this at the end of the webinar as well. Some upcoming events. We have our monthly webinars here on the second Wednesday of every month. Registration is open for our December webinar, which is another sneak peek for the Advancing Care Conference, but this one is about resources and tools available for your facility's infection prevention and control training needs. And our January webinar will share more soon. We'll be announcing virtual and fingers crossed in-person courses in 2022 soon, so stay tuned for that. And as always, we have our online community platform called Mighty Network, which contains really great content and is a good way to connect with your peers from across the country who are interested in TeamSTEPPS and team training in general. And then finally, we're excited to relaunch registration and share the agenda for our Advancing Care Conference that will take place in person March 7th through 9th in Chicago. And if you've been to former TeamSTEPPS or AHA team training conferences in the past, you'll see similar themes that exist surrounding team performance, quality improvement, well-being, and education. And so during the pre-conference, I do want to highlight that we will host our first in-person master training course since the start of the pandemic. So we're really looking forward to that. And there's a large cohort of you on this call who are likely master trainers, so I do want to call out that those who are master trainers, you'll see that we have a discounted registration rate available for you. We're also opening up a call for poster proposals, so if you have a poster you'd like to display, please complete that proposal by January 7th, and we'll chat in some more information there. So enough of me. I'd like to introduce you to Ross Ermintrout. Ross is a TeamSTEPPS master trainer, consultant, and recently retired from a long tenure at the University of Washington in Seattle. Ross will be presenting at the Advancing Care Conference, so like I said, this is meant to be a bit of a teaser or a primer on what you can expect this March. So Ross, I'll turn it over to you.
Great, thanks Jen, and hello everyone. And as Jen said, I'm Ross Ermintrout. I'm a nurse by background. And I spent my entire career at the University of Washington in Seattle at the health system there. I started out as a new grad in the Burn Center at Harborview Medical Center, which is one of the hospitals for UW Medicine. Spent about 9 years in the Burn Center, transferred to the Trauma Intensive Care Unit from there, was a critical care educator for a while. I had a little over 20 years at the bedside between those two units in critical care education. And then I got involved in patient safety, and I was the patient safety officer there for about 10 years at Harborview. my last 6 or 7, and I became a TeamSTEPPS Master Trainer in 2009, and UW was one of the regional training sites. So I've been teaching TeamSTEPPS since 2009. In 2013, the University of Washington Health System decided they wanted somebody to focus on TeamSTEPPS throughout the health system, and so I became the clinical director of team performance for my last 6 years or 7 years in the system, responsible for implementing TeamSTEPPS throughout all 4 hospitals, 200 clinics, et cetera. At that point, I worked for University of Washington Medicine WISH, which is the WWAMI Institute for Simulation in Healthcare. So I worked for the Simulation Center, and I'm going to incorporate some simulation stuff there as we go through this presentation. I retired a little over a year ago, just as the pandemic started, so I never got my 36-year retirement party, but I'm not bitter about that. I went and bought new golf clubs instead, and moved to Denver in June of this year to be, my wife retired in May, and we moved to Denver to be with our grandkids. So I am currently living in Denver. All right, enough about me. So what are we going to do today? Well, the objectives for today are to explore core concepts related to high reliability organizations. And I know most of the people on this webinar are probably familiar with those core concepts or principles, but that's okay. I'm going to go over them somewhat briefly and kind of relate it to some other things as we go through this. I want you to understand the role of TeamSTEPPS in supporting high reliability behaviors. And I'll say this a couple of times, these are not 2 separate initiatives. HRO and TeamSTEPPS are not separate initiatives. And then finally, identify opportunities to engage leadership and frontline healthcare workers to make this happen in healthcare. All right, so the topics are today: what is an HRO, high reliability organization? What are the 5 principles? How can TeamSTEPPS facilitate healthcare becoming highly reliable? And how do we get engagement to succeed? But first of all, I want to give my disclaimer. This is kind of how I roll. I like to get up on my soapbox somewhat frequently, and those who've heard me speak before, you know I do this. And then when my dad was alive, he used to say to me, Ross, if you're not living on the edge, you're taking up too much room. And so during this presentation, I'm going to go on the edge a little bit. And then finally, I like to tell stories because I think stories help drive home the message. And when we're trying to engage frontline staff into this, no matter what their role is, stories kind of help bring it to life for them. So with that, I'm going to start with a story. There's a book that came out. It's written by Norman McLean back in 1992 is when it was published. And it was called Young Men and Fire, and it's about smoke jumpers. And in this book, Norman McLean describes the events of August 4th, 1949 in the Mann Gulch fire, which is in the Helena National Forest, which is about 20 miles north of Helena, Montana. So I know there are a few people from Bozeman Health that signed up, and you're probably familiar with this area of the Helena National Forest. Anyway, smoke jumpers were firefighters that would jump out of planes, they'd parachute from planes, and they'd go into these remote areas to fight these wildfires and forest fires. And on this day, on August 4th, they were deployed to this fire in the Mann Gulch. And the fire was occurring on the south side of the gulch, and there's a river at the bottom, and then there's the north slope on the other side. And a forest ranger spotted the fire, called it in. And that day, 16 smoke jumpers boarded that plane to go fight that fire. It turns out one of them got sick on the way, and so he didn't jump with them, but the other 15 jumped and got to the ground and landed they hit the ground a little bit after 4 p.m. in the afternoon and had some issues going on with the air turbulence. And by the time they were able to all get together and get all their equipment together, it was pushing 5 o'clock or so, and now they had to hike to where the fire was. Now, Wag Dodge, who was the foreman for the group, was head out to meet up with that forest ranger who had called in the fire. And so they got together, Wag Dodge and the forest ranger, and then they reconciled with their team again. And now we're pushing 5:30 or even later in the afternoon. Now, they had established this fire as a terminology they used to use. They called it a 10 o'clock fire, which meant that this fire was pretty routine, and they would fight it, and it would be done. They would have it out and controlled by 10 a.m. the next day, and would be on a plane or heading out back home. Well, that's not the case of what happened here. So, like I said, Wag Dodge returned, met with his team again, and he realized that now this fire was going to be a little worse than he expected. It was 100 degrees air temperature out there. The wind was kicking up. There was very low humidity. And now they were kind of in terrain that they weren't extremely comfortable with. They were used to fighting more forest fires, whereas this was more of a wild grass fire. Anyway, Wag Dodge recognized that the fire was going to be a problem. In fact, they were starting some spot fires where they were on the north side of the slope. The spot fires were jumping over the river. And his original plan was to use the river as an escape route. Well, now that was becoming blocked. Now, it gets a little controversial here on exactly what happened and who knew what. But it appears that Wag Dodge knew there was a sense of urgency here, but it wasn't clear that everybody else on his team realized there was a sense of urgency. Anyway, at 5:45 p.m., Wag Dodge tells his team, we need to start heading up the hill. We need to get away from this fire. So the problem here is they're running up anywhere to 40% to a 75% slope to get away from this fire. But they do at 5:45. They start heading up, carrying their packs, all their equipment, because that's how they are. That's how we've always done things, right? Same in healthcare. You know, this is how we've always done things, and we're not releasing our packs because that's our identities. So they start running up. Well, at 5:40 or 5:53, so 8 minutes later, Wag Dodge realizes this fire is extremely out of control now, and they're going to have trouble getting to the top of this ridge before this fire overtakes them. When they first started, follow-up research and stuff, that it was figured that the fire was moving at about 110 feet a minute. But at 5:45, 8 minutes later, they figured it was moving at 620 feet a minute. So Wag at this point yells to his team to drop your tools, drop your packs, which they did, but it took them 8 minutes to get to that point. They continue running up the hill, and he realizes there's no way we're going to get to the top of this ridge in time. This fire is going to overtake us. At that point, he stops, he pulls out matches, and lights the grass in front of him. So it burns the grass up the hill in front of him. He then steps in and lays down in that burnt out area because he's effectively removed the fuel in that area for the fire. And he yells at his team to join him. Well, they either thought he was crazy, no way. There was clearly not a shared mental model on why Wag Dodge did what he did with the rest of the team. And so, to get to the kind of long story short part, 12 men, or 3 men made it to the top of the ridge. They outran the fire and made it to the top of the ridge. Unfortunately, one of them was so severely burned that he died very soon after. Wag Dodge survived with minor injuries, and 12 of the men were overtaken by the fire before they got to the top of the ridge. So 13 men died in that fire that day. So a devastating story. From that, what Wag Dodge did is develop what they called an escape fire. That area that he burned out in front of was an escape fire. That's still a term they use in firefighting now, and you can read more about it. But it's basically an area that protects you. And what happened here is Wag Dodge did some innovation on the fly. He had to think quick, and that's what we're going to kind of focus on a little bit about today. There's 2 systems that we look at. We look at preventing systems from setting us up to failure, but then we also look at when the system does fail, how do we respond to that failure? Okay, so what does this have to do with us? It has to do with healthcare. First of all, we need to address medical errors, teamwork, and communication from within. Right? We need to have innovation in an emergency on the fly. Things like algorithms are good and whatnot, but sometimes we have to innovate on the fly. And in order to do that, we need to have a culture where people feel comfortable speaking up. And that's where really TeamSTEPPS is going to fit into how we do TeamSTEPPS, we will become high reliable. We need to move away from how we've always done things. Now, just think to yourself. I told you I was in healthcare for 37 years now, and I can't even begin to tell you how many times I said it, and I heard other people say, that's the way we've always done things. It doesn't work anymore. Healthcare can learn a lot from the airline industry, the nuclear industry, NASA, military, smoke jumpers. You know, those are all high reliability organizations. We know, and I'm the first one to use these as examples when I talk about patient safety and when I do TeamSTEPPS training and whatnot. But we're not these other industries. And if you haven't been reminded of that by people you presented to, then I'm surprised, because I've been reminded of that numerous times. But that doesn't mean we can't learn from them. But we still need to work on our systems from within. We need to function as an HRO. And you know what? Frontline healthcare professionals are best set to help us with that. Okay, and I'm going to spend a little bit of time on that as we go through this presentation. Additional regulations or regulators, policies and procedures are not going to fix systems. We need those. They're important. I'm not saying they're no good, but they're not going to fix the system by themselves. Bring everyone to the table, including regulators. Bring everyone to the table. But too often we don't do that. We send a bunch of people that aren't actually doing the work at the bedside to come up with a plan, and then wonder why we get pushed back, okay? And finally, we don't need to have separate initiatives. I mentioned this earlier. TeamSTEPPS concepts and tools will help us become highly reliable. Okay, so what are high reliability organizations? And you know, I don't know how many of you heard Elaine Higgins and Pamela Leonard talk last month, big class month, but gave some great descriptions of what HROs are and stuff, and really broke it down on the principles, and it was really an excellent presentation. But so I'm not going to go into real detail on all this, but I do want to mention some things. First of all, really there's a practical definition for HROs is somewhat elusive, to tell you the truth. And then you got to ask yourself, well, do some organizations strive for low reliability? No, I don't think so. It's just that some are function at such a high risk and complex environment that they have to be high reliable. And so that's that next bullet point. You know, it's commonly used to describe organizations that avoid catastrophes in environments which are high risk and complex. There's two distinct processes we're looking at. How do we prevent system failure? And then how do we respond when there is system failure or any kind of failure, especially in healthcare? And it's a mindset way of thinking. So it captures crisis in its early, more responsive stage. Right? We're really good at doing process improvement and quality, continuous quality improvement, total quality management, but they look backwards to help us in the future. That's great. We need to do that. And that's where we start looking at how do we prevent system failure. But HROs really function in a real-time interaction. Something happens now, we have to respond now. We can't wait for that root cause analysis to figure out how we're going to respond now. And as we go through this again, I'll give you some examples of that. All right, and then there's this little bit of conflict that goes on, or value shifting, when you think about HROs. Some HRO values seem to oppose each other, right? And I'm not a big fan of obedience, the term obedience, but let's just go with it on this one. We want you to be obedient, but we also want you to take initiative or be innovative. Take initiative. And we want you to conform, but also want you to be creative. Okay? So how does that work? How do we do both of those? Well, you got to think about HROs and think about healthcare. We work in two kinds of environments. We have that structured of routine operations from day to day. Preventing system failure is the priority. That's conformity and obedience, right? A classic example is central line checklist. been out for, I don't know, 15 years, maybe not that long now, I don't remember, but prior to that we had a huge complication rate for central lines throughout the country. And then when Don Berwick kind of introduced the 100,000 Lives campaign and central line checklist as part of that, we realized that if you did the same, if everybody put in the central line the exact same way every single time using this checklist, that the complication rate would go down, and it did. It dropped to 1% or less in most areas of the country, which is pretty impressive. But people pushed back on that. But we put a system in place that made it the right thing, the easy thing to do. One of my favorite examples, and for those of you who've been in healthcare for 20 years or more, you probably remember this, tube feeding tubing used to fit into IV tubing or a HEP lock. So you could, and it happened around the country on more than one occasion where somebody hooked up a patient's tube feeding, go in and it'd be dark in the room and try not to wake up the patient, and they'd hook up the feeding tube to the patient's IV unknowingly. And patients died. I mean, it was a tragic event. It was a catastrophe. Well, why would you design it so it would fit into IV tubing? So eventually they changed the design. So the IV or the tube feeding tubing doesn't fit into IV tubing. I mean, it's just crazy that it took a while to get there, but we did get there. So that's preventing system failure. And that's where things like the continuous quality improvement, PI, and RCAs, those are great. That's where we go, wow, we got to fix this. But then there's the emergency response. And I think that's the other environment we function in. Emergency response is the priority, unstructured or violent, of the crisis. That's where we need initiative and creativity. And I think COVID-19 is a classic example of where we had to do. There's tons of examples out there, but as I was thinking about and putting this presentation together, I'm going, well, you think about when COVID-19 first hit and these patients were coming to the hospital and severe acute respiratory distress, and you know, as they like to say, it was innovation on the fly, or I heard several comments saying we're basically building the plane while we were flying. And that's because we didn't really know how to react right away to these patients. And we thought, okay, let's do this. That worked, but not so well. Let's do, and you know, we started proning patients and found that helped their respiratory status. So shooting from the hip, just being innovative, and taking initiative and being creative. And it's not, these aren't competing priorities here. There's obedience versus initiative, conformity versus creativity. It's just, we have to look at the environment at the time of where we're functioning. Okay, so here are the 5 principles of HROS. Sensitivity to operations, preoccupation with failure, deference to expertise, commitment to resilience, and reluctance to simplify. And I'm going to go through this somewhat briefly, and at the very end of this PowerPoint, I actually have a crosswalk, and I'll talk briefly about that when we get there. All right, so sensitivity to operations. We know that frontline employees are better positioned to recognize failure or potential errors, able to identify opportunities for improvement, and have a unique view of a current situation and unexpected situations. So we need to tap in to that frontline people when we're deciding, trying to work through how do we prevent system failure, and then when we get there, how do we respond so there isn't a catastrophic event? And that's really where other high reliability organizations have mastered, right? And again, we're not the airline industry, but they have so many contingency plans in place. If something goes wrong, that plane's probably still going to stay in the air. You know, everybody has this. So we have to work through it a little harder because every patient's different. And we're never quite sure what's going wrong, but we do have the ability to start thinking about it up front. So we're looking at more of this big picture understanding or situational awareness. And you think about the Mann Gulch fire. Did the entire team recognize the danger? Well, that's not completely clear. In fact, after the fact, they found photographs of the fire after it hit junk, the river, these spot fires. And so one of the firefighters was taking pictures of the fire. And you know, it could be that maybe this was for future reference, but as you read more about the incident, it's like, well, Were they just taking pictures of the fire because they wanted to have pictures of the fire and didn't actually realize the sense of urgency was going on? Well, did Wag Dodge do a good job of sharing that with his team? And so as you think about, okay, what TeamSTEPPS tool might have made a difference there, and, just a brief up front, what could possibly go wrong, and we can get that a little bit more later, but a quick huddle, and it's not like they had time to sit around for 3 or 4 minutes for a huddle. They literally had seconds. And if Wag Dodge, would have pointed out what exactly was the problem here, maybe that sense of urgency would have gone up. All right, so how do we look at this in healthcare? And we need to have that speak-up culture. And I always like to say, we need to encourage people to state the obvious. I don't care what it is. A lot of you on this webinar are patient safety quality people, and I know you've all been to these RCAs where you've reviewed things, and almost always somebody knew something was up, but was afraid to speak up. And so working hard to get people to state the obvious, and when they do state the obvious, don't ridicule them if everybody in the room already knows that's the case. All right, we need to have a shared mental model. So again, as you state the obvious, we're more likely to get to that shared mental model. And of course, the mutual support tools of Custom to Challenge just are every single principle of HROs. You have to maximize this. You think about stories about the 18-year-old on the aircraft carrier who stopped all movement of the jets when he sees a wrench on the runway or whatever they call that on the aircraft carrier. 18-year-old. I worked with an OB doc at UW. He was career military, and some of you probably know him, Pete Napolitano, great guy. He talks about his time in Afghanistan and was in a helicopter and was about ready to land, and there was an 18-year-old on that helicopter, and all he did as they were going into this landing zone is yell, pull up, pull up, pull up. And nobody asked why. You're an 18-year-old. What do you know? They just pulled up, and it turns out that landing zone was being attacked. And so this 18-year-old probably saved a lot of lives because he was empowered to speak up. All right. So that's sensitivity to operations. Preoccupation with failure, which is one of my favorites. Any failure or deviation from the expected is reviewed for opportunities for improvement and to prevent continued failures. It's kind of like doing the same thing over and over again, expecting a different result. So we want to prevent continued failures. It is necessary to address all technical, human, and process failures immediately and completely. Fixate on how things might fail, even when failure has not occurred, and near misses are considered opportunities. So think about, especially that third bullet point, third and fourth, they really jump out at me. Fixate on how things might fail. Well, let's look back at that fire. They called this a 10 o'clock fire. They went in with this attitude that, yep, routine fire, going to have it out by 10 a.m. the next day. What could possibly go wrong? Well, did they ask that? Steep slope, high air temperature, low humidity, increase in wind. In fact, they weren't even familiar with the terrain. I don't even have that listed. What could possibly go wrong here? Well, they didn't plan for that. And in healthcare, and in this case, a quick brief might have said, well, this is really a steep slope. We have the river, but what happens if that river escape route goes away? Then what are we going to do, right? Have a plan in place. So briefs, huddles, situation monitoring, having contingency plan. I like handoff tools. There's a couple of handoff tools out there, right? TeamSTEPPS have the iPass the baton, but I really like the Boston Children's Hospital handoff tool that they did a lot of research on. It's called iPass. Some of you have probably heard of it. It's a great tool, and I'm not going to go into detail about it, but at the end, it has a contingency plan, right? So when I'm handing off, it's if this happens, do this. What if? Are a part of that. And that's really important, I think, as we move forward. All right. Deference to expertise. Authority does not necessarily mean expertise. And that's tough, I think. It's been tough for us, although, I told you I've been involved in patient safety now, going on 15, 16 years. I guess I lose track of time. And it's changed significantly. It's pretty impressive. In fact, quite often when I speak with groups, and if I have, residents in the room. They're always my favorite people to ask, people a year or 2 or 3 out of med school. And I'll say, what do you think? What is the hierarchy issue? And sometimes people don't want to speak in because maybe the attending physicians are in the room too. But for the most part, 15 years ago, they say, well, there's still a huge hierarchy thing. I still don't feel comfortable speaking up. Whereas now, I'd say 60 to 80% of the time, they're going, yeah, I feel like we're empowered now a little bit more to speak up. So we're heading in the right direction. We got to go, expertise takes precedence. And on-the-ground subject matter experts or local knowledge help provide situational assessment and response. So I'll give you an example. One thing I didn't tell you is there was a period of 3 months back, or 4 or 5 months, I don't know, back in 2013, after both my kids were through college and I'd been working full-time for years and years and years, and I decided, I'm going to take a little bit of a break here, and I'm going to go back to the bedside. And I did that, I think, in July of 2013 or June of 2013. And I was out there. I was only working 2 days a week. I was really being casual and enjoying life. And I got a call from administration asking me if I would go into the sterile processing department and be an interim manager in that department. And I'm going, well, you guys must be stoned because I know nothing about sterile processing. And they're going, well, that's okay. That's not the important thing. We need somebody with some leadership skills and can work with the team up there. And it's just been a problem for a long time with that group. So I finally agreed to do it, went back to full-time and went in there and started talking to the staff. And it turns out every single staff member in that department, every single one, had some sort of letters of discipline in their file. And it was a big department. There was like 60 of them. I'm going, how could that possibly be? And each one of these discipline letter things, I don't even know how manager had time, was because OR tray would get to the OR and it'd be missing one of the tools that they needed, one of the, blanking on the equipment, whatever they needed. Or there was a hair, which is not a good thing, a piece of hair in the sterilized tray. So there are all these things going on. And so that, again, I knew nothing about central processing at the time. And so I started talking to staff, and nobody had ever asked them why this was a problem. What they'd done is just said, you need to fix it, right? You just need to do a better job. That doesn't work. And not only in healthcare, it doesn't work anywhere. And so it turns out you talk to them, well, it's really hard to see because our lighting's poor in here. The previous manager took away their chairs, didn't want them sitting down while they were working. So you start asking them and let them be the ones that tell you how this is going to make it work. You get response. You get ownership by them, but you also get people that want to do better, right? And it was pretty amazing to watch this group, how not only did they start having less mistakes, less hair, less missing these pieces of equipment in the trays. They just started doing a better job. That wasn't me, not because I was their manager, it's because they own the process. And they took pride now in what it looked like. So that's deference to expertise. But let's think about it. It means respectful regard or concern rather than submission or yielding. Custom to challenge are great tools. Now, I know everybody on this call knows somebody that's really good at speaking up. I mean, I worked with staff that were outstanding at speaking up. Unfortunately, when they spoke up, they ridiculed everybody around them by challenging them on what their ability to do their job. And that's not what we're talking about. And custom to challenge doesn't challenge people on how they do their job. We have a concern about what's going on, and that's the important part of this. All right, commitment to resilience. Anticipate failure or potential errors to effectively manage unexpected events. Involves identifying errors and innovating simultaneously, and dynamic process of correcting and creating solutions. So in that fire, it was okay to drop their pads. They probably should have done it 8 minutes earlier, but they didn't didn't really have that sense of urgency maybe that they should have. Simulations could have helped identify potential pitfalls. And I told you I was at the Simulation Center, and this is an outstanding way to not only look at commitment to resilience, all these HRO and TeamSTEPPS concepts, right? One quick example I want to give, does it really make sense for the leader to be the one trying to intubate? And this is a classic simulation that we ran doing mock codes with our OR teams. And we were doing one day, and the CRNA was responsible for the airway in the room that day, and got into this mock code, and it just wasn't going well because now the CRNA had to intubate. At the same time, he was trying to run the code. So he's losing situational awareness. He's focused on the airway, which is an important part, right? He should be focused on the airway. And things are chaotic. And afterwards in the debrief, we talked about that a little bit. And he's going, well, no, you know, I'm the expert in here on airway, and this was the airway issue, so I should be leading this code. And then the more we talked about it, the more he realized I did lose situational awareness. I did lose this. So you don't have to have the expert in the room being the leader. And we have a saying, we used to say, leaders can't be doers, because once you become a doer, you no longer can keep situational awareness. And so it's important to have somebody step back and be a leader that can keep that situational awareness. Those are the kind of things you can find in these simulations. Yeah, we're trying to make sure people are good clinically, but we also want to make sure in these simulations we function well as a team and become an HRO. All right, so reluctance to simplify. Embrace the complexity of the organization and conduct a detailed analyses like root cause analysis to understand problems. And, you know, we've got to have those RCAs. We've got to have this continuous quality improvement, et cetera. But we need to reject simple explanations for failure. And we did that for many, many, many years in healthcare. Like, we blame the end user, the sharp point, sharp end user, the person that made the error. We didn't look at what the system, how them led them up to that. And the example I have here is because the nurse didn't read the label. Some of you might recognize that. It actually comes from Dennis Quaid's newborn twins, who both received 1,000 times the dose of heparin than they were supposed to get. And I'm not going to go into big detail. But Dennis Quaid was interviewed afterwards, and that's what he said, because the nurse didn't read the label, which partially is true. But if you look at this, and if you're not familiar with that heparin incident, heparin in 10 units per mil, it comes in a vial. That's what they're supposed to get. It comes in a vial, you know, with a blue label on it. Heparin 10,000 units per mil comes in a vial, same size, with a lighter blue label on it. So 1,000 times dose difference. You know, and it looks almost identical unless they're sitting next to each other. That's where that error started. And like I said, I'm not going to go into detail on this. You can look it up. You can Google Dennis Quaid's newborn twins. You can read all about this. But it happened 26 times around the country. The exact same error happened 26 times, and 2 of these infants died. Dennis Quaid's kids were okay, but 2 of them died. So, you know, we can't just say it's all because the nurse didn't read the label. They were set up to make that mistake. It's the same thing going back to that fire. They simplified this fire. They said it's a 10 a.m. fire or a 10 o'clock fire, and we're going to be out of here. But they didn't talk about, well, what could possibly go wrong here? What system's thing going on? You know, that fire, that wind is blowing out. It's really hot, and it's very humid. Or looking at an example of an infant in the ICU with lung and heart disease. And, you know, the pulmonologist comes in and looks at this child, and the patient's intubated, says, you know, this infant definitely has lung disease, but he should be able to get off the ventilator. And then the cardiologist comes in and takes a look and says, yeah, this infant has cardiac disease, but it shouldn't be bad enough that this patient can't get off the ventilator. And they're struggling with it. Well, meanwhile, the respiratory care practitioner is kind of graphing the ventilator settings on this infant and starts looking at him and realizes, well, they get to a point of level of ventilation, and instead of getting better, the sats actually get worse. The O2 saturations get worse. Patient's doing a little worse. And what's happening is this patient has a respiratory shunt that's leading to a cardiac shunt. Basically, their lungs, as they set the ventilator sets higher, the oxygen from the ventilator is going to areas of the lungs that aren't responding, and then non-oxygenated blood is going into the heart. So you're getting this cascading event. And if you look at it at an individual level, it shouldn't affect this patient getting off the ventilator. But if you bring it all together, it makes sense. So it's a very complex example. But here's my favorite one, policies and procedures. The procedure says, drives me crazy, and I'm sorry if I offend anybody with that, but it does. Procedures and policies are very, very important. I will never say you can't have them. But I'm going to be honest. I wrote more procedures and policies in my last 15 years of healthcare than I did in my 20 years working at the bedside. And that's not because I was lazy or didn't care. It's because they don't change culture. Procedures are important. Policies are important. I did a Just Culture course. I became certified in Just Culture probably, well, it's 2017, so whatever that is, 4 years ago, I guess. And I was sitting in my course, and there was multiple professions in there, but most of us were healthcare. And we got into some discussion about blood and blood transfusion errors, and really the discussion wasn't even on the transfusion, it was on the type and cross and the mislabeling of the forms that was set up for type and cross. And there was an administrator in there from the health system, and I can't remember where they were from, and I wouldn't tell you if I could remember. But anyway, we had a little bit debate because it drove her crazy that the policy said and the procedure said you did this way on this form. But she kept saying we keep having these same mislabeling errors occur. And I'm thinking that's probably not uncommon elsewhere too. Well, hopefully not too common. But we have this thing going on. And so I say, well, if it keeps happening, do you think there's something wrong with the form? Well, no, the procedure, and literally said it to me over and over and over again. The procedure says it. And I'm like, but it's not working. So why don't you ask? And they would punish people for one time. And, you know, they call it one of those red flag things, right? Blood errors are a big deal. I'm not denying that. But let's look at the procedure and figure out what's the issue here. Maybe we need to redo this form. Maybe we need to ask people that are actually doing the work, how are we going to make this so this doesn't occur so much? So anyway, don't simplify. All right. So those are the 5 principles. And now I want to get in a little bit on how do we engage frontline staff and leadership. Now, I kind of alluded to this as we've gone through this talk, and I thought, and I'm very adamant about how do we get people to want to do this. But let's think about where we are right now. Times are really, really tough. Right? Healthcare, being a nurse out there. My wife, I told you she retired in May. She's also a nurse. I have a daughter now that works at the University of Colorado Health System that's a nurse. It's stressful. There's no doubt about it. It's very stressful, and people are stretched to the limit. So we have to figure out how we're going to do this without stretching them more. But first and foremost, everyone doesn't have to completely understand every principle. And that's key, I think. They're all interrelated. And you'll notice as I went through those principles, I kept coming back to the 10 o'clock fire. I kept coming back to the lack of shared mental model. And they're all interrelated. And there's no first principle to learn. As learning and using even one of them will make another principle more understandable and accessible. Right? So kind of what I'm leading to here with that next bullet point is consider combine TeamSTEPPS education with HRO education. You don't have to have this HRO education, especially now. You don't have to have HRO education and go, okay, here's the 5 principles. You know, we're going to do this. Here's this principle. Here's this principle. I think it's good to teach them. I'm not saying don't. But what if you kind of did, we're going to have TeamSTEPPS course, and during this course, we're going to talk about how this is going to make us a high reliable organization. Right? So if we get really good at custom to challenge, we're going to take care of just about every one of these principles. Right? Maybe, yeah, I would say just about every one of these principles. So I'm presenting on cuffs. And I say this is a two-way street. You know, you can't just teach every nurse in your organization what cuss is. You teach everybody what cuss is. You teach them that it's a two-way street. You can't just teach people to cuss but not talk to people about how you respond when you're cussed at, right? You got to go both ways here. And say, you know, if we get there, deference to expertise is going to happen, because in that scenario where something is going wrong, and I have local knowledge because I've worked in this unit for a long time and I've been taking care of this patient for my last 4 shifts, I have some local knowledge and I need to feel comfortable sharing that local knowledge. That now makes us start heading towards HRO status. Okay, hopefully that makes sense. And then I kind of have these bullet points. The more I looked at this, I'm like, oh shoot, I kind of got these bullet points backwards, but that's okay. I want to go to the second bullet point first. This cannot be a top-down concept or top-down initiative or whatever you call it. I say the frontline staff have to own the process. Doesn't mean they have carte blanche to do whatever they want, right? Well, you know, you want us to become an HRO, and part of that's taking initiative and innovation on the fly. Doesn't mean that 100% of the time. Yeah, but you have to give them ideas and thoughts on how they will feel comfortable doing the right thing at the right time. I like to, again, those who've heard me talk before, I'll talk about ownership versus buy-in quite a bit. Buy-in is really, hey, I've got a really good idea, and I want you to buy into it. Versus ownership is, you know what, we're going to do TeamSTEPPS, we're going to become an HRO, we're going to become very high reliable. That's going to happen, but you are going to kind of help us get to where we need to be. So now the frontline people get to own this process, right? Frontline professionals have the best view of the system issues, and we need to tap in to them. Again, education, policies, and procedures alone won't make healthcare reliable. Again, one of my pet peeves, one of my soapbox things here is, how many times did I hear that we have a chain of command policy when you think something is not going right? Every organization, healthcare organization in the world, I'm sure, has a chain of command policy. And it says, go up your chain of command if you have concerns about what's going on. That's great. You got to have that. But that doesn't change culture. And at 2 in the morning, the chain of command policy is really not helpful. What's helpful is you've established a culture in that department, in that area, where people feel comfortable speaking up. And sometimes it's not even the chain of command you have to go to. It's your colleagues, your peers that are working with you, your deference to expertise, right? And people have to feel comfortable with that. Another thing I get is, how do we, and there are a couple pre-webinar questions about how do we engage, and that's the title of these slides, how do we engage frontline staff, but also how do we engage leadership? And sometimes we spend a lot of energy, I think, on making sure, oh, we got to get every single person engaged right away. And unfortunately, that's hard to do. But I guarantee you, no matter where you work, there are people that want to do this. They want to do TeamSTEPPS. They want to be, they really embrace these HRO principles and stuff. Tap into them. Let them be your champions. And, I hear often, and it's tough, I get it. I'm not saying it's easy, but I often hear that in those organizations where their providers may not be employed by the hospital, it's even harder because they don't really owe anybody anything. But there's still people in those private practices, I guarantee you, that want to do this. Tap into them and let them help you get these other people. That's really important. And be innovative. Again, times are tough. We need to figure out how we're going to get this education, this training on TeamSTEPPS and HROs out there. You have to be very innovative. And if you're going to do web-based stuff, that's great. I think that's fine. I would rather do it in person, obviously, but that's not so easy anymore. But if you're going to do web-based stuff, make it interactive. And I think the AHA video toolkit that shows different TeamSTEPPS tools is a way that will work. It's an interactive platform that you can start getting people thinking on. And finally, we need to start reframing the discussion. People want to know what's in it for me, right? And again, that Pete Napolitano, that OB doc I told you about, retired, came to UW, retired from the military. He calls it WIFM radio, what's in it for me? Right? People want to know, we all know this is the right stuff for patient safety, for better patient outcomes, et cetera, but we still want to know what's in it for me. And so you have to tap in, well, you know, we're not taking away your ability to be a leader. What we're doing is making it empower your team so everybody respects each other. And, you know, as a person that's only been around maybe for 6 or 8 months, if I get that feeling that people respect me, then I'm going to stay around longer because I like to work with people that I can work with well. What's in it for me? And then, as I mentioned, that ownership versus buy-in. They get to own the process. Yeah, I know we've talked about doing all these other things in the past, but this time you're going to own what it looks like, okay? And same thing with leadership. Leadership sometimes say, well, we can't afford it, we can't do this, we can't do. Well, you know what you can't afford is turnover. And those groups, those organizations that have done really well with TeamSTEPPS and heading towards that high reliability organization, they have decreased turnover. There's data out there on that. Improved patient satisfaction scores. That's important. There's one group I worked with at the University of Washington. They 5 quarters in a row, that area had the highest patient satisfaction scores in the entire health system. Now, I can't say TeamSTEPPS is all that, but it was sure a big part of it. You know, patients were seeing staff were happy. Well, that's going to be, and you know, there's more and more data coming out and better patient outcomes as we get better at team communication and becoming high reliability organizations. Now, one thing I want to talk about real briefly here is avoid bashing data into frontline staff. They need to know, right? They need to know that, hey, our patient satisfaction scores are not so good, or our fall rate's kind of high and stuff. But spend more time on changing that to make it more relatable to them. And that's where you get buy-in, and I hate that word, sorry, ownership. That's where you get people really want to move forward with this, okay? So think about how you talk to them about it, how you speak about it. Don't say, we're going to do this. All of this health system is going to be high reliability organization. You got to kind of break it down into what does that mean directly for them. All right, so I mentioned this crosswalk earlier, and Brian Ross is an anesthesiologist, retired anesthesiologist at UW, and I worked with for a long time with TeamSTEPPS, and we worked at the AHA, Chris Hunt and Jen Braun, and on putting this crosswalk together probably 8 or 9 years ago. But I'm not going to go into detail on it. You can peruse that when you get a chance. So all 5 principles and the behaviors that we see with that. All right, so key takeaways. High reliability emerges within an organization when an individual person supported by the organization engages a discrepancy or system disruption. TeamSTEPPS tools and concepts can provide the mechanism to do this. We have to establish that speaking up culture in order to meet that bullet point. The behavior of individual people, teams, and organizations as a whole. It has to be across all these areas. You can't just have, okay, we're just going to do this group. It has to be all 3 levels, the people, the team, and the organization. And TeamSTEPPS can facilitate an organization becoming an HRO. I strongly believe if we adopt TeamSTEPPS tools and concepts, high reliability will follow. We don't need to separate them out. And then combining TeamSTEPPS education with HRO can facilitate this process, which I already talked about. And then finally, I wanted to say we need to build our escape fire from within. And we're not going to call it the escape fire. I guess we could. We need to keep looking from within our own team to within our own people to see how we're going to become a high reliable organization. So some other things to consider is sense making some sense out of the chaos. This is by Carl Weick. And then some human factors engineering, and I will incorporate that more into my conference talk in March in Chicago, and hope to see some of you there. So here's a few references. They're on the slide, so I'm not going to go through those. And I thank you, and I will turn this back over to Jen for any questions anybody might have.
Thanks, Ross. This is excellent. I'll echo our friend Joe Carlucci, who chatted in at the start that we never miss a Ross Armentrout presentation. So thanks for that.
Thanks, Joe.
We don't have a ton of time left, so I'll get maybe one or two questions in. So one that I think is kind of a broad question, but Dana asked a good one, but she says that it seems that organizations have switched gears to focus on HRO principles without really understanding how TeamSTEPPS fits in or really solves a lot of those issues while moving an organization towards becoming highly reliable. So how do we get orgs or organizations to understand that TeamSTEPPS is user-friendly, and if adopted, it can help propel an organization towards becoming highly reliable? So how do we get leaders and organizations to understand that link and that practicality of team?
Yeah, that's such a great question, because I hear that a lot too. Is that, well, we're going to focus on HRO, and then maybe we'll do TeamSTEPPS, or just leave TeamSTEPPS out of the discussion, and that's really where we have to say, well, and I kind of think that bullet point that if we become really good at TeamSTEPPS, and we don't even have to do all the TeamSTEPPS tools, just some of those, become proficient in that, high reliability will follow. And that's how we need to present it to HR or to leadership and administrators, and say, well, we want to become an HRO facility. That's great, but you can't just tell people that these are the behaviors we want. You have to give them the tools to help them change their behaviors. And so saying we just need to have a culture of speaking up is important, but what are the tools that we're going to make it so people can speak up? Or just giving somebody the ability to cuss doesn't mean that's going to change culture. And I didn't get into this, but most organizations, they have something, maybe it's a recorded message that they show on the internet to new hires, they say from the CEO or whoever it is, somebody high up, that says, we want everybody to feel comfortable speaking up here. That's great, but that doesn't change culture either. What changes culture is, and starting to get to that high reliability, is when somebody at that brief, that's running the brief, that has a fair amount of respect and power here, starts talking at the end of the brief, says, hey, Kimberly, if you have a concern about something that's going on, I want you to cuss at me today. That's where you start changing culture, which gets us into preoccupation failure, deference to expertise, all these other principles. So that's what I try to, anytime somebody says, well, we really want to be HRO, I say, well, you could get there faster with TeamSTEPPS.
Yeah, I couldn't agree more. Yeah, the TeamSTEPPS is really the how to get teams to the place that they want to be, and I really like the crosswalk that you put together. So encourage folks to check out the slides and see how TeamSTEPPS really complements HROs, and it's not this or that. It should be a both and.
Right.
So I know we're near the end of time, so yeah, for those that have additional questions, Ross included his email on the other slide right here. And again, come to the Advancing Care Conference in Chicago to hear more from Ross. But in the meantime, please complete an evaluation form that will be sent to your email here shortly. And then finally, here is the text, the code, and the phone number to text for your CE credits. So with that, I just want to say thank you again for joining us, and we hope to see you in March. And thanks again to Ross for an awesome presentation. Take care, everyone.
Thank you, everyone.